It can spike to the point to where it'll just knock you on your knees and put you in bed.
Pain. We all feel it. But for millions with chronic pain, it lingers for months, even years.
It's like 10 times worse than a toothache.
From the YMCA volunteer to the Marine wounded in Iraq and a mother struggling to continue her mission to save abused animals. Follow 3 stories of people in pain.
It just eats away at you, it devours you, and eventually it can take your soul.
Explore different treatments and weigh the risks and benefits of prescription drugs.
The use of painkillers in the United States has become an epidemic.
We'll have a panel of experts plus portraits of patients as we discover what happens to the body in pain. Funding for Body in Pain comes from the Dr. Donald J. Goodman and Ruth Weber Goodman Philanthropic Fund of the Cleveland Foundation, the Margaret Clark Morgan Foundation, the McGregor Foundation, the Woodruff Foundation, and the Community Foundation of Lorain County.
My name is Lisa Novak. I'm 38 years old. I run a nonprofit animal shelter. No animal is to be left behind. That is our motto. No animal is to be left behind. We deal with a lot of animals that are abused by people, a lot of cruelty that occurs. This year, so far, the rescue organization, the volunteers have saved 263 animals. I know chronic pain. I know the suffering that occurs, and I know the pain that comes with it. I was working at an animal hospital. I was lifting a 120-pound dog, and the dog fell, and I ended up ripping my abdomen and getting multiple hernias. No matter how much I rubbed my side or my leg or tried to apply heat, you couldn't. It was a deep, penetrating pain, almost like being stabbed. Chronic pain, it takes away everything. I think it makes you feel inadequate. It causes depression. And I think your children are impacted more because they don't understand. You know, at one time you were doing something and now you're broken. I ended up having to sell my home because I wasn't making the income that I was. I gave up almost everything just to try to survive.
My name is Yvonne Wood. I'm 62, and I know the whole nightmare of chronic pain. In 2002, I was diagnosed with serious arthritis in both knees. And at one point, it was so bad that I was in a wheelchair. I was really immobile. It affected my work in the fact that I was an office manager, and I wasn't able to move around. I wasn't mobile. Because of the fact that I could not do the job that I was responsible for doing, I retired in 2002 on disability. It's like a throbbing, nagging, gnawing pain, and it's there while you're sleeping. I mean, there's no comfort level. You sit up, you have pain. You lay down, you have pain. Have you ever had a toothache where the pain is just throbbing like a pulsating pain? It was just that painful. Chronic pain affects your whole lifestyle. It affects the way you live, and it affects the choices that you make as to how you do things on a daily basis. It affects you mentally also. It's so painful that you just don't even want to be bothered with people. It isolates you.
I'm Derek Young. I'm from Warren, Ohio. In Iraq, 2005, I was wounded in an explosion, and since that time, I've had to live with chronic back pain. I enlisted in the Marine Corps after high school in 1998. In 2005, I was part of Operation Iraqi Freedom. I was deployed with 3rd Battalion, 25th Marines Weapons Company. The headquarters is over in Brook Park, Ohio. Unfortunately, the public would probably remember us as being the unit with the heavy losses in early August of 2005. Our mission was to patrol the roadways and support any of the foot movements and to disrupt any type of insurgent activities within the Al-Anbar province of Iraq. On May 7th, 2005, at approximately 3:30 in the morning, we were returning from a patrol. I was the vehicle commander and I sat in the right front seat. There was 5 of us total in that vehicle. And that's when my vehicle ran over anti-tank landmines. You hear ringing, some things are slow, some things you remember, some things you don't remember. It's kind of hard exactly to say how I was feeling at that time. It was somewhat of a state of confusion. And you just go into react mode and rely on your training. The other guys were wounded a lot worse than me, and so I wanted to make sure that they were the priority. I, had some lacerations, some back injuries, some nerve damage in my legs, concussion. Just like with any veteran, everybody has different symptoms and different diagnosis with whether it's PTSD, traumatic brain injuries, chronic back pain like myself. There's a combination of emotional and physical pain.
So chronic pain really derails people, really changes people's lives. Dr. Qotaiba Tabah, you've been treating pain patients for 20 years. You're head of pain management at Metro Health. You've probably seen everything under the sun when it comes to this.
Well, Kate, that's absolutely true. I have seen a lot and I treated a lot of patients. What comes to my mind first is the case that I have been, after I did my cardiac surgery in the Cleveland Clinic and I switched to anesthesiology and critical care. There's a case at Southwest Hospital that I got a patient in the ICU who is in a coma after committing suicide, and actually the patient expired. The police brought with him his memoir or his, principally diary about what's happened to him. And when I read his writing, it was because of chronic back problem that he had, and he became isolated from his family and his community, and he lost his job. This sad story by itself for me as a surgeon, when I considered pain as just a principally temporary thing, you give them a couple of Percocet after surgery, a couple of pain medication, everything is gone. Never seen that impact on the patient and the society or the family like in this case that I've been experienced probably 20 years ago.
So it can be riveting to patients and families. Dr. Jeffrey Janata, you're a psychologist. You've studied pain for 20 years. You've treated lots of patients. Tell us how this kind of chronic pain that we're talking about is really different than the kind of pain you have when you cut your finger.
Well, we all experience pain. Pain in an acute sense is the body's warning sign that it's been injured. And in that sense, pain can be very helpful. It is helpful. We otherwise wouldn't know that we had hurt ourselves. Chronic pain, by contrast, is that system now gone into a sustained mode. Chronic pain is defined as an unpleasant and emotional sensory experience that persists over months and months. Typically, we classify it as being 6 months or more, that now has taken on a life of its own, where the body stays in a cycle of experiencing pain, even independent of an originating injury.
And there's many different causes of chronic pain, and that's very much the case in our 3 profile patients.
Mm-hmm.
Why? Here.
Whether it's feeding or grooming, working with animals is a 24/7 job and something Lisa Novak was able to fully embrace until she encountered debilitating leg pain.
It was going to literally be the end of the shelter. It was going to be the end of what I've done my whole entire life. And it was going to be the end of these guys, of saving animals.
Lisa was in pretty bad shape as far as her pain, because it really had interfered with her daily living activities. She had a little boy at home and she couldn't care for her family, she couldn't care for her animals.
Novak's current doctor, a pain specialist, suspects Novak's leg pain may have resulted from nerve damage suffered during hernia surgery.
The medical treatment that I received actually caused more pain. I was hoping for a cure, and instead I got a problem.
Doctors say nerve damage can occur in up to 10% of operations for hernias or other surgeries involving the ribs or chest.
An operation can sometimes accidentally damage small nerves that are hard to see during the surgery that may be cut. Sometimes it could be from the retractor, sometimes it could be from positioning during surgery.
Nerve damage pain is called neuropathic. It's different from other types of pain. Normal pain, also called acute pain, is protective and results from intact nerves doing their job to let the body know something is wrong. Let's say you cut your finger. Sensing trouble, the body's defense system issues a red alert, a so-called inflammatory response that causes nerve endings at the injured site to send a pain signal to the brain.
So the pain signal travels from the skin along special nerve fibers all the way up to the spinal cord, and from there it is conducted into the brain.
The pain subsides as the finger heals. But in neuropathic pain, damaged nerves malfunction. They are basically nerves gone wild. They continue firing pain signals to the brain without any connection to an outside injury.
So you may be feeling pain in your chest or in your arm, even though there's no injury to the chest or the arm.
Lisa Novak has neuropathic pain, and the first doctor she saw prescribed strong narcotics, but Novak opted not to take them. Instead of drugs, Novak would try several different treatments over the next 6 years. For Novak, the only relief has come from a new freezing treatment. In a procedure known as cryoablation, doctors use special scanning technology to guide treatment probes to the problem area.
So as you can see, here's an ice ball forming at the tip of the probe. And that ice ball is actually placed very, very close to the nerve. And by freezing and thawing, what happens is we denature small proteins inside the nerve. By denaturing the proteins inside the nerve, we essentially kill the function of the nerve or kill the pain for a while.
I have life again. It's like giving me back my life.
Doctors caution that cryoablation does not work for everyone, and Novak will likely require repeat procedures.
Hey, bud!
But for now, Novak is once again functioning and able to keep the animal shelter open.
I only have a bad day every once in a while versus a bad day all the time.
Nice throw, bud.
Nine years ago, at age 53, Yvonne Wood was losing her independence due to debilitating pain in her knees.
I could not walk without a cane or a crutch, but otherwise I was in a wheelchair. Even though I was at home, I could very well have been in a nursing home because I wasn't capable of doing anything for myself.
Close to 50 million Americans have some kind of arthritis. Wood has a severe form known as rheumatoid arthritis. The lubricating fluid in the knee produces excess chemicals that wreak havoc on the cartilage, the cushion for the joint.
That excessive fluid has chemicals in it that start to eat away at the cartilage. And it kind of creates a whole cascade effect of enlargement of the joint, destruction of the cartilage, loss of the cartilage, painful motion of the joint, limitation of the joint, and then the patient gets progressive destruction of that joint.
The pain intensifies. Eventually, both of Yvonne Wood's knees had to be replaced with artificial parts. But joint replacement surgery only offers a partial solution. Patients also need to take medications to try and manage both the pain and progression of rheumatoid arthritis. Lifestyle changes also are usually necessary, which in Wood's case includes losing weight.
It's a real struggle because I do have a problem with my portion controls. Pain will cause you to eat. Yes, it will. It does. You know, and if you're not able to get out of the house, whatever's in the house, you're going to eat it, because if you're in pain, you go to the refrigerator and say, oh, I'll eat this and maybe I'll feel better.
So weight does play an important role. And what we see in arthritic joints is for every 1 pound of weight that a patient loses, about 4 to 5 pounds of weight are taken off the joint. So if you have a patient who loses 10 pounds of weight, they essentially are taking off 40 pounds of weight from their knee joint.
5,
6.
One of the most useful exercises for arthritis sufferers is water aerobics. It not only helps reduce weight, the resistance of water helps strengthen muscles without stressing joints. And there's an added benefit for almost any exercise.
It helps the body produce various chemicals that are actually self-generated painkillers that our body can produce, and it can only be produced by doing exercise. We can't artificially give all those chemicals to our patients.
Unfortunately, studies show that people with arthritis, those most likely to benefit from exercise, are the least likely to do it. Yvonne Wood wants other chronic pain sufferers to know working through the pain of exercise is worth it.
Even though some days are worse than others and I may have pain, I just push my way through and do the pain. And generally afterwards, I feel a lot better. And had I given in to the pain and not done anything, I would have felt a lot worse.
One knee up, one knee back. One knee up, jog it around.
The 3rd Battalion, 25th Marines, touched home to a hero's welcome. During the Ohio Regiment's 7-month deployment to Iraq, it lost 48 members. Another 241 were wounded. Derek Young was one of them. With his Humvee flattened in an explosion, Young was left with an injured back and other wounds. Despite his injuries, Young stayed on to complete the tour.
Just because people get hurt doesn't mean the war stops. It's tough at times, you know, your back hurts, and you're tired, you're worried, you're scared. So what? You just deal with it and move on.
Be it on the battlefield or in regular civilian life, most back pain stems from a combination of factors. The discs, the cushions between our vertebrae, naturally start to degenerate around age 30. The joints in the spine may also become inflamed due to arthritis. Such changes can be compounded by military training and/or traumatic injuries, like the explosion Derek Young experienced. Young suffers from a combination of spinal problems, including several herniated discs. The jelly-like center of the disc moves out of place and presses on nerves in the spinal area.
And the yellow parts are the nerves?
Yes, these are the nerve roots coming out, and then the more they are irritated, the more often and common the shooting pain down the leg.
Depending on the type of day, it could be just an aching pain, just an annoying type pain, and some days you're bedridden. It's like riding a roller coaster. Roller coaster of pain, you have your highs and lows, but it doesn't stop.
Young's injuries caused him to be medically retired as a staff sergeant at age 29. But once a Marine, always a Marine. It took a while for Young's strong warrior attitude to surrender to the fact he needed help learning to cope with chronic pain.
And it was limiting me to where I was feeling so worthless, so to speak. I wasn't able to do the things that I like to do. I wasn't able to move around the way that I wanted to. Something needed to be done.
On your worst day, how bad is your pain?
On the worst day, I'd probably hover right around a 7.
Young eventually sought help from the Lewis Stokes Cleveland VA.
I'm mixing steroids with local anesthetic and normal saline.
Using radioactive dye and advanced scanning technology, Dr. Mashurab injects a steroid and a numbing agent directly into the affected area of Young's spine.
You'll feel a little pressure sensation here. The goal of the epidural injections, or what people refer to them sometimes as nerve blocks, is to address the neuropathic pain that is coming from the nerve. The nerve sometimes is firing constantly, and what the steroids can do is reduce the repeated and sometimes spontaneous firing of these nerve fibers. Derek, how are you? Good to see you.
Nerve block injections only work temporarily, but they got Young functioning enough so he can work out again. Exercise helps build strong core muscles to support the spine. As you can see from these patient stories, managing chronic pain is a multifaceted proposition. Freezing nerves, spinal injections, physical therapy, surgery, as well as complementary and alternative therapies like acupuncture are a few of the many strategies specialists are using. There's also nutrition therapy.
We know that low magnesium in our bodies can cause an increased perception of pain.
And the use of pain psychologists.
And the very definition of pain is that it is a physical and emotional experience. And so again, that shows the importance of the mind-body connection and that both halves are making a contribution to what the person's experiencing on a daily basis.
But probably none of these approaches is as common or as controversial as the use of prescription painkillers, narcotics known as opioids. Lisa Novak chose not to take them.
I have a 10-year-old son. I don't want to be doped up. I want to be able to be level-headed and not hooked on narcotics.
Retail sales of opioids like OxyContin and Vicodin nearly doubled in a recent 10-year period. Yet their use to treat chronic pain remains clouded.
While effective for a subset of patients, they can be detrimental for another large proportion of those patients. And therefore, their use has to be judged very, very, very carefully.
Is that happening?
Unfortunately, no. There's not enough education for the practitioners. In medical schools and nursing schools, really, practitioners are not taught who are the patients that should not be receiving these medications and when to be careful with these medications.
Dr. Mashurab is among those who generally steers clear of prescribing opioids, especially for veterans.
So the veterans coming from Iraq and Afghanistan, they're young, they have significant musculoskeletal injuries, and they have all of these chronic pain complaints, but it's complicated by the presence of PTSD in a large number of them. So they're a great setup for them to obtain these medications and end up staying on them while the right thing and the right treatment is not being offered.
But many pain specialists are open to using opioids at least as temporary tools for managing chronic pain. There is widespread agreement on one thing: patients need to lower their expectations. Most will not see their chronic pain go away completely. In fact, many will only get a small amount of long-term relief, no matter what treatment is used. That's true for drugs or any of the other therapies we've mentioned. As one analyst quipped, chronic pain relief is an oxymoron.
Pain's always going to be there, but if I let it limit me in the things that I like to do, it's going to affect my quality of life, and I won't let that happen.
So medicine is the most common way to treat chronic pain. And there's a whole gamut of medicines, but we're going to focus this discussion on the use of opioids, Vicodin, OxyContin, narcotics like that. And even though none of our profile patients use them, they are a very important part of treatment. We're not going to be talking about their illegal use when they're diverted and sold on the street. We really want to discuss their legitimate use for chronic pain patients. So let's start with the benefits. Dr. Tabal, what do you see as some of the benefits of using these drugs?
There is no doubt about it that opioid therapy, it was one of the most oldest therapies that's been used by humanity since 3,500 years BC. Till now, it is the same medication that derived from opium. These medications are very effective in controlling pain. Now, we know that it is very effective in controlling acute pain. In the chronic pain scenarios, it's a great medication if it's used in the proper population, in the proper patients, and in the proper scenarios, as give them a window of opportunity to achieve functionality so they can improve their activities and advance to a second level of their life.
So Dr. Janata, what do you say in terms of the benefits for these patients?
The benefit, I think, is that we can provide patients who are in pain with a window of opportunity that they can use to engage their own activity in the pursuit of healing.
So it's like a transition tool?
Well, what it is if you can relieve pain enough that patients can exercise, that they can re-engage in recreation, re-engage in social activity, go back to work, engage with their families, now you've created a system that gets the patient on the road to healing more quickly.
Now, what are some of the risks?
Well, opioid is a medication actually that it's so funny that many elderly patients, for example, will say that we'll give them a little bit of Vicodin. They come back, Dr. Tabaa, I don't want this thing here. The constipation is more horrible than my pain. I will prefer to die in pain. I don't want to have a constipation. One of the examples of how horrible the side effect for certain people. We noticed that there's some patients develop something called opioid-induced hyperalgesia, which is that means the patient become more sensitive to the pain despite the fact that they're getting large doses of morphine or pain medication. So the more pain medication you give them, they become more sensitive and more to stimuli that causes their pain.
So it can make their pain worse?
It causes, yes. Now we have respiratory suppression, that the patient may end up having significant respiration, especially a patient with obese, so they have sleep apnea. You give them these opioids, may stop breathing, so and they die from it.
Breathing problems.
That's right. Sexual dysfunction is another things that happen with the chronic opioid usage.
And Dr. Janata, what are some other risks you see?
So I see really three major risks. The hyperalgesia that Dr. Tabaa mentioned, that is that opiates can make pain worse. The second is that we unnecessarily are providing an opportunity to expose a vulnerability to addiction in a population that may not otherwise be exposed to it, and we have to be able to address and assess that risk up front, which can be hard to do. And the third is that chronic pain is accompanied in the majority of cases by depression, and depression can masquerade sometimes or accompany the symptoms of pain or be expressed as pain. And so the risk is that if you apply a central nervous system depressant, like an opiate, to someone who's already depressed, it can make the depression worse.
So they could feed off each other in a negative way?
Yes.
And, you know, no matter what treatment, whether it's the opioids, whether it's a surgical intervention, it seems like the patient really has to take an active role in this whole treatment picture.
Well, when we think about the importance of optimizing function, if we use any medical treatment, opiate or any other, it has to be in the service of optimizing function. And so we can create a quid pro quo, where a patient uses an opiate but also engages themselves in the active pursuit of health.
So no matter what, the bottom line, there's no magic pill to manage chronic pain.
So here's the takeaway if you or a family member suffers from chronic pain. Number 1, you likely will never be completely pain-free. Number 2, you can't be passive. Patients have to take an active role in treatment. And finally, chronic pain management requires a multifaceted approach, which often includes lifestyle changes as well as therapies for the mind, body, and soul.
To learn more about chronic pain, visit our website at health.ideastream.org. There you'll find web-exclusive material exploring complementary and alternative remedies for pain, including massage and acupuncture, plus a report on migraines. View special content provided by our partner, Net Wellness, a consumer health website offered as a public service from medical schools at Case Western Reserve University, the University of Cincinnati, and The Ohio State University. There's also a place to share your experience with chronic pain. Go to health.ideastream.org. Watch, listen, and click. Funding for Body in Pain comes from the Dr. Donald J. Goodman and Ruth Weber Goodman Philanthropic Fund of the Cleveland Foundation, the Margaret Clark Morgan Foundation, the McGregor Foundation, the Woodruff Foundation, and the Community Foundation of Lorain County.